Everyone, and welcome back to those who just joined. I am about to go live with Dr. Ikhena-Abel, who is MD at Aspire Fertility, Austin, Texas, a Prelude Network clinic, and we will be discussing everything there is to know about follicles and fertility. So welcome back if you just joined. This is a conversation not to miss. Make sure you watch until the end because we have some fantastically insightful questions for Dr. Debo to answer today. So please also, if you have your own questions, feel free to ask live. I believe she's just joined, so let's get definitely one to watch. We're going to be talking about follicles, fertility, what really matters, what we should know, and I believe she's here. Hello, Dr. Debo.
Hello, can you hear me okay?
Yes, perfect. How are you?
I am doing well. I'm sorry we had so many technical difficulties.
Not at all. We're here now, so that's perfect. I would love for you to please introduce yourself and tell us a bit about you and what you specialize in.
Yes, thank you for having me. My name is Dr. Deborah Ikhena-Abel. I go by Dr. Debo as well. And I am a fertility doctor, also known as a reproductive endocrinology and infertility specialist. And I practice with Aspire Fertility in Austin, Texas.
Wonderful. And today we're going to dig right into follicles and fertility, what really matters, what people should know, what people ask you as an expert in the field. So for people who are kind of new to fertility, perhaps seeking treatment or beginning stages, how would you explain what follicles are and why they are so important to your fertility journey? And how does that follicle count relate to an overall fertility potential?
Yeah, so whenever I explain fertility to my patients, I like to use the analogy of the ovary on ultrasound. Looks like a gray chocolate chip cookie with a bunch of black chocolate chips. And each chocolate chip is a follicle. Each follicle has one microscopic egg inside of it. And the number of follicles on your ovaries tells us how many eggs you have available for that particular month. Now, in a given cycle where you're just kind of taking medications, so you're not taking any medications, you're just going through the cycle on your own, your body will choose one of those follicles to ovulate, so release an egg from at ovulation. And at the end of that month, all of those follicles die away along with the egg inside of them. And so your follicle count is a measure of your fertility, of your egg reserve specifically, the number of eggs you have available. And your follicles are the egg houses for the eggs that you have available for that particular month.
And could someone have a different follicle count from one month to another?
For sure, you can have some variation. It shouldn't be a dramatic variation. So you wouldn't go from having 4 follicles to having 13 follicles the following month. But you may have 11 follicles one month and then have 13 the next month and then have 12 the next month because, there is some fluctuation, but it should fluctuate around a median, which is your normal. Now, over time, that number goes down. So if you have a follicle count of maybe 13 this year and you go back in a couple of years to be evaluated, that number may be down to 10 or 9 because we expect that just as your egg count decreases over time, your number of follicles, which is a reflection of your egg count, will decrease over time as well.
Makes complete sense. And could you have different numbers of follicles on each ovary?
For sure, yes. Our bodies are not perfectly symmetric, so you will have one side in most cases that has more eggs than the other side. And sometimes that can go back and forth as well.
That makes sense. And how many eggs are contained within a single follicle? And could you retrieve follicles and find that there are no eggs inside them?
Yeah, so typically we expect each follicle to have one egg inside of it. Now, when we do an egg retrieval, we expect that about 80 to 90% of the follicles will have an egg inside of them because some eggs will not have, some follicles will not have an egg inside of them. Now, as we get older, or if we have a very low egg count, the likelihood of having empty follicles does increase. And so that's something that we may see in some patient populations more than in others. But I'd say overall, when you do an egg retrieval, we expect about 90% of those follicles to have an egg inside of them.
So when people are coming to you and they're during the stimulation process and you're scanning them, does that give you a good indication of how many eggs you might get from a cycle as you get nearer to retrieval?
Yes, for sure. So even when I do the first ultrasound and I do the antral follicle count and I find out what the total number of follicles available is, that gives me a sense of what I would expect down the line in a future IVF cycle. And then as we go through the IVF cycle and we follow the follicles over time, we also look at the size of the follicles. And by the time you get to the trigger, any follicle that is about 13 millimeters or more is in the running for having an egg present at the time of retrieval.
Mm. That actually takes me on to one of my other questions, which is obviously your speciality is judging like when to trigger someone because you want the follicles to be that optimal size. So what's the parameters between sizes from sort of like the smaller size to the larger size you really want to push it to?
Yeah, so typically when we decide when to trigger, we're going based on the size of the largest follicles. And I typically like to have a couple that are about 20. So somewhere between like 18 to 22, because our bodies are flexible. So it might not be exactly 20, it might be 21 or
Mhm.
19. Um, but then I also look at the size of all of the follicles. So for example, if someone has a total of 10 follicles that are in the running and they have one that is 22, but all the rest are under 15, I'm probably going to keep going a little bit longer so that I have more follicles that are closer to 20. But overall, in most cases, if you have a couple that are around 20 millimeters or so, and the rest of the follicles are following closely behind, then that would be usually a good time to trigger.
Does that make a difference then in terms of your stimulation and when you might trigger someone based on their age as well?
Yeah, so the age can definitely be a factor. So we would look at the age combined with their estrogen level, for example, their progesterone level as they go through the cycle, and also if we have any historic data from a prior cycle, for example. So if there's someone who in the past has ovulated earlier than anticipated, then that may factor in. And then in some patients who are on additional medication, so sometimes you have patients who may be going through an IVF cycle or egg freezing cycle because of a history of, let's say, breast cancer, and they're on a medicine called letrozole to keep their estrogen levels low as they go through the cycle. Now, studies show that in those patients, you do want to push them a little bit further so you have better maturity. So in that case, I may push to like maybe more like a 22 size follicle versus 20. Again, just kind of considering all the factors that are at play with that particular patient.
Yeah, that makes complete sense. And are there sort of factors that influence this process in terms of whether a follicle would have an egg inside it? Is that in someone's control?
You know, I would say probably not. Usually the follicle either has an egg inside of it or doesn't. A lot of the time, you're not able to, necessarily do anything differently to
Mm-hmm.
influence whether or not your follicle will have an egg inside of it. I will say that for the most part, we expect that most of the follicles will have an egg inside of them. And a lot of the time, all of the follicles will have an egg inside of them. But again, like I said, in certain situations where either you have a low egg count or when we're older, we start to see that there might be more empty follicles. But it's one of those things that unfortunately you're not able to control what your follicles do with regards to the cycle.
Absolutely. Absolutely. We've had a couple of questions. If the largest follicle ovulates, will all follicles ovulate at the same time?
So it depends on the size of the other follicles. So if the largest follicle ovulates and the other follicles are very small, then they're not going to, because they're not ready to ovulate and they cannot really even receive the signals to tell them to ovulate. But if the largest follicle ovulates and the other follicles are also close behind, then very likely they're all going to ovulate at the same time. So it really depends on the size of, so like there are some cases where, your doctor may say, I'm going to trigger this large follicle, but we're going to keep going for the rest of the follicles. And that's because those other follicles are so small that they're not going to ovulate
That makes sense.
at the same time. Yeah.
Mm-hmm. Absolutely. Thank you for that. And
Yeah.
do you use an antagonist to stop ovulation?
Yeah, so that is one of the ways that we prevent ovulation during the cycle. Because when you're going through an IVF cycle, what you're trying to do is delay ovulation until you have the right cohort and the optimal cohort of eggs for that cycle. And so typically we will use an antagonist to do that. This is administered as an injection that the patient will take, and it basically works by preventing your brain from releasing the hormone called LH, which is a hormone that triggers ovulation. Now, there are other ways your doctor might do this. So another option would be to take a medicine called Lupron, which is an agonist, but it basically does the same thing. And also, there's recent data showing that also giving progesterone at a particular dose can also prevent ovulation as well while going through an IVF cycle.
Interesting. Do you have patients? I was one of these patients who panicked a little bit that I didn't have the amount of follicles I wanted at the beginning of a cycle, and then ended up actually being pleasantly surprised by the number of eggs that were retrieved, having worried the whole way through stimulation that there weren't going to be the number of eggs that I wanted.
Yes, this happens all the time. And I try to tell patients, when we start the cycle, most of your follicles are going to be small, and that's okay. And so patients worry like, oh, there are only two follicles that are,
Mm,
greater than 10. I'm like, well, you're on the fifth day of your cycle. So of course,
yeah,
most of the follicles are small. And then as you go through the cycle, the follicles will start to grow in size. And then it's almost like you're watching like a flower like bloom, right? So you start off in this, there'll few petals. And then as you go through, more and more petals start to show themselves. And so more and more follicles start to respond, especially if we were expecting that to be the case. And so if you come into the cycle, you have a good egg count, and, we've already discussed that we are expecting a pretty good outcome. Most of the time, it's just a matter of being patient and, trusting the process.
absolutely. I think that's really good advice. And onto that, how do you and Aspire Fertility Clinic track and measure follicle development?
Yeah. So as you go through the cycle, whether it's an IVF cycle or egg freezing cycle, you will be coming in for monitoring visits every couple of days. And we track the growth of the follicles by doing transvaginal ultrasounds at these appointments. We also check hormone levels. So we check an estrogen level because usually these follicles contain an egg each, and those eggs will make estrogen. And so by tracking the estrogen levels, you're able to tell what's going on within the follicle for the most part. We also check a progesterone level because that gives us a sense of if for whatever reason you were to ovulate prematurely, then that would cause a pretty significant spike in your progesterone. So that can be an indicator as well. But really, we're monitoring you very closely with these frequent ultrasounds and blood tests as you go through the cycle to monitor how your follicles are responding, how your ovaries are responding.
So a combination of blood and also ultrasound, transvaginal ultrasound. Hmm.
Exactly.
And we mentioned it, but if you were to pick like the ideal follicle size for conception, whether it's naturally, IUI, IVF, would there be a size that you
I'd
could
probably
say?
say somewhere around 20
Okay.
is a good place to be. So plus or minus a couple of millimeters. Keeping in mind that, by 20 I mean 20 millimeters. So these are very small increments, but 20 is a good kind of average to look out for.
Mm-hmm. Okay, that's good to know. And this is a good question. Can undergoing IVF treatment negatively impact follicle development and or egg quality?
Yeah, so as far as we know, this is not the case. So whatever eggs we get during the cycle are the eggs that were there to begin with. We're not able to necessarily change, like I'm going to assume you mean like going through an IVF cycle this month
Mm-hmm.
affects follicle development the next month. I'm
Mm-hmm.
going to assume that's what you're asking
Yeah,
me, right? Okay.
exactly. Exactly.
Just making sure I'm answering the right question. So basically, whatever we do with these follicles are not able to impact the next set of follicles because those follicles that we have access to, we know if we didn't retrieve them, would just die
Yeah.
away at the end of that month. We don't currently have the technology to access future eggs for future cycles, which is part of why if you have a low egg count, we are kind of tied to whatever your ovaries can give us in that particular month. And so if you go through an IVF cycle, you don't have to worry that it's going to affect next year's, eggs or next month's eggs because each month has its own group of eggs for that month.
Do you see differences? Because I've heard this from someone before, and I'd be interested to know whether you've seen this. Like patients responding differently depending on the season.
Huh. I have not seen that. I haven't seen like the full like season of the year, like in winter versus summer. I haven't seen
Yeah.
that. What I have seen, and there is data to support this as well, is that when patients do cycles kind of back to back, we do see a better response in the subsequent cycle. And the thought
Interesting.
is that and the thought is that the first cycle almost kind of primes the ovary. It's almost like, the ovary has done it once, so now it knows how to
Hmm.
do it again. And so sometimes even when you keep the protocol exactly the same, but you do a cycle right after the first cycle, you see a slightly better response. Overall, of course, there are exceptions to every rule, but overall, you see a better response in that second cycle
That's
than in the
fascinating.
first cycle.
That was actually a
Mhm. And
question that just came
oh,
through. What are your thoughts on
okay.
back-to-back cycles?
Yeah, and then we typically you see this benefit, it lasts for about 3 months after the previous cycle. So it doesn't have to be like you go right into the cycle. It does last for a period of time afterwards.
What would be patients' reasons for doing back-to-back cycles?
Yeah, so if patients, for example, are trying to maybe bank embryos for a particular family size, so they are like, I want to have 3 kids, then that might be a reason to do back-to-back cycles. If someone has a genetic condition that they're tested for in both of their partners, where there is a high chance that they may need more embryos because they might, because you're losing more embryos when you're doing genetic testing plus testing for whether or not it's a normal embryo, so that might be a reason to do back-to-back cycles. The most common reason is patients with a low egg count. So patients who have a
Okay.
low egg count or who are older, we just know that overall outcomes tend to be poorer. And so the more cycles you can do, then the more likely you are to get the number of embryos you need to move forward with building your family.
Yeah, that's really, really useful to know.
Mm-hmm.
This is also a great question, actually, something I was about to ask you.
Mm-hmm.
Lifestyle changes, supplements, nutrition, exercise. Is there anything that people can proactively be doing? And this lady's asked for 40 plus,
Mm-hmm.
but to generally increase the likelihood of follicles responding and improved egg quality.
Mm-hmm. Yeah, I would say that the most important lifestyle factor, if this applies to you, is to stop smoking or any kind of nicotine. So that we know for sure affects how your ovaries behave, how your ovaries respond to medication. So that would be the first place to start. Other things that may help to improve your outcome from the cycle, as far as nutrition, the diet that has been most closely linked with improved fertility outcomes is the Mediterranean diet. And I always
Mm,
tell patients, I don't think it's because olives are better for you than apples necessarily, but it's really because it's a plant-based diet. It's a diet that is really rich in fruits and vegetables, in whole foods, legumes, and also is more like, in terms of animal protein, it's more fish, maybe some chicken versus beef. So all of these things we know are better for ourselves, for overall health, in terms of, being really rich in
mm,
antioxidants. And so all of those can come together to improve your outcome from a fertility treatment cycle. As far as supplements, the one supplement that I do recommend to my patients is coenzyme Q10, because it
mhm.
does have some data to suggest that it helps to improve both egg and sperm quality. So that's something to definitely consider. And in my patients with PCOS, I usually recommend inositol as well.
Would you recommend that patients try and start that 3 months before they have treatment, if possible? Like, is there an optimal time to be prepping prior to treatment?
Yeah, I would say 3 months before is a good time. However, I would put in the caveat of if you have a low egg count or if you're 40 and older, I would not wait 3 months
Mm,
exclusively to get the benefit of the supplements or the lifestyle
mm,
changes, because at that point in time, we know that there is going to be continued decline in egg quality over those 3 months, and the rate of that decline is probably going to outpace the benefits that you may get from the lifestyle changes and the supplements.
that's interesting. Is that another reason, going back to what you said before about why some people might do back-to-back cycles? Because if
Exactly.
they were to get pregnant, they'd be waiting a whole, another year or
Exactly.
longer before
Exactly.
potentially retrieving more
Exactly.
eggs.
And based on their age or their egg count, waiting a whole year may not be an
Hmm.
option for them.
That's really sound advice. Has anyone got any other questions for Dr. Debo whilst we have you here live? Please do ask. Is there anything else you think that we should discuss that we haven't on this topic?
First of all, I wanted to say that this was a very, I really liked the topic. I've never had a conversation about follicles specifically.
Yeah.
So I felt like, oh, this is a nice take. And it's a question people have all the time going through
Hmm.
the cycle. And I think it's important to know that one, when you're thinking about follicle sizes going through an IVF cycle, I have patients who are like, oh, can we wait till all the follicles are above
Mm,
18 or above 16? And one of the things to keep in mind is those follicles are not going to, the egg and the follicles wouldn't be there forever. And so if we
yeah.
push it to the point where every single follicle is above 16 or above 18, then you may get to a point where the larger follicles are now like 28 millimeters or 30 millimeters, and those eggs may start to atrophy because, again, these eggs are on a clock in the sense that they're only there for about, for a few weeks. And so we want to keep that in mind when we're kind of making that decision. So if your doctor is, having you take your trigger and you're like, oh my gosh, I still have follicles that are like, 13 millimeters. It's not because they are ignoring those follicles, but they're trying to think of the whole picture. Like what is the best point to get the best of all the follicles, and avoid losing the ones that are kind of already ahead of the pack.
Do you find that your patients are quite well read and they're sort of Googling things online and coming to you, sort of asking questions based on what they've read?
I find that for sure. And I think that there are people who come to me with like very good data, actually. So they would, I have a lot of patients I have two patients who are researchers, like not in medicine, but like, so they come to me with like very good data and, they have kind of thought about it the way that I would think about it. And that's always great because then I can like reaffirm what they're already thinking. And then sometimes the patients will come across people online who are, spreading misinformation for whatever reason, whether it's to promote a product that they're selling or to garner followers. And so in that case, it's an opportunity to kind of discuss, the data that they're presenting to me, what parts of that data may be true, what parts of it are not true, and then to explain why, because I think it's, you can't just say, oh, this isn't true, end of discussion, but to explain like, actually, this is what is actually happening, and these are the actual like factors that we're putting into consideration.
Absolutely.
Yeah.
And then, of course, that's your like specialism, isn't it?
Yeah.
To be looking at the protocol people are on to like work out what's happening with the follicles and how
Exactly.
you're changing the medication in line with that.
Exactly, yes. And then I think another thing I would tell patients not to do is to not compare themselves to their friend who went through IVF.
Mhm.
I have a lot of patients who will say, well, my friend went through IVF and she had 25 eggs. And I'm like, don't do that. Everyone's ovaries are different. Everyone's born with a different set of cards. And so, like they say how they say comparison is a thief of joy. It's a thief of joy in IVF as well, or egg freezing.
100%.
And
Yeah,
so to really try to just, focus on their own journey. And, at the end of the day, all you need is one good egg that can result in one healthy baby. And so
absolutely.
there are people who will have less eggs, but will be
Hmm.
successful. And unfortunately, the people who may have more eggs, but may not be successful. And so really, not comparing themselves and just kind of, focusing on their own journey as they go through the process.
So it's about quality over quantity.
Exactly. Quality is important.
Hmm. Two more questions. Well, another question if you have time. What are your
Yeah.
thoughts on growth hormone for those with low AMH?
Yeah, so I will sometimes consider growth hormone for my patients. There is data to suggest that in women who are 40 and older, it may increase the likelihood of a live birth from going through an IVF cycle. Now, that being said, it's an expensive medication. It's not covered by insurance for IVF. It's only covered for growth hormone deficiency. And it's not a guarantee. There are no guarantees in biology or in medicine. And so I think that's a conversation that you should have with your physician who is familiar with your course, how you've responded in prior cycles, with the rest of your medical history to determine if that's something that may be beneficial for you or not. But it's something that I do discuss with my patients, especially if they're 40 and older and or have a low egg count.
That's a great question, and that's really insightful. Thank you so much for sharing that.
Yeah.
If anyone else has any other questions for Dr. Debo and would like to find out more, please do head to our link in bio. The team at Aspire Fertility in Austin would love to help you, and we've also linked up the Prelude Network so that you can have a look at all of the clinics across North America to find what suits you best, and speak to a specialist to get some personalized advice and treatment started. So thank you so much for your time. Really,
Thanks
really
for having
appreciate
me.
it. And I believe I'll be meeting you very soon. I'm coming over to Texas, Austin, Texas, in a couple of
Oh,
weeks
nice. Oh, I'm looking
to
forward to
visit
meeting
the
you.
clinic. So
Of
very much looking
course.
forward to seeing you in person as well.
Same here. Same here. Thank you for having me.
Thank you everyone for joining. It was a pleasure chatting with you.
Thanks. Bye.
Thanks. Bye-bye.